babies, and babies, who are IUGR babies, they also develop retinopathy of prematurity. And the other thing is, it is spontaneous regression is there. Don't go with the idea, younger people who are sitting here, that ROP is a bloody very malignant kind of disease and we cannot afford to do some treatment, and children who come with ROP, they all go blind. Don't have this kind of conception in your mind. And the most important thing is, and the most encouraging for us, that disease is preventable. I think all of you people sitting here, maybe I do not know how many percentage, if you have done the laser in ROP cases, you have got a wonderful result. And you are so happy, and the parents are also very happy. So that's the point I wanted to make. Having had the understanding, basic understanding of retinopathy of prematurity, this is zone 1, this is zone 2, this is zone 3, this is stage 1, 2, 3, 4. I have made my own division or classification. And this is one treatable ROP, means what Doxa was saying, he has injected anti-VEGF in those cases. Those are the cases which can be very well managed by the laser. And now some people are giving anti-VEGF injection, which is debatable. And the other one is the severe ROP, which is the zone 1 ROP, which I was talking about. And then of course there are ROPs which are stage 4 and stage 5. I hope you understand what I am saying. If you don't understand, you can ask me. Now, ET ROP classification, as just now, I think, Parijat, you made a discussion about a point about this. ET ROP type 1 is zone 1. You see, what is important here? What you see very common here, this is a plus disease. So what does it indicate? What does it indicate? If there is a plus disease, this child will need a treatment. Very simple analogy. And that's why I say that if, even the pediatricians, now all of us who have done MBBS, we are supposed to see the fundus. And if there is a pediatrician, if he dilates the pupil, just sees the posterior pole, and if he finds plus disease, or even in an general ophthalmologist, if he sees the plus disease on the posterior pole, this means this baby is going into severe ROP, and please refer this baby to a retinologist or an ROP specialist or whatever you want to call it, and this baby will need a treatment. It's a very simple thing. And this is the classification. And with this ET-ROP, what we have been able to do is, we have been able to decrease the unfavorable outcome. An unfavorable outcome as termed by who termed this unfavorable outcome? Of the CRY-ROP study. And at the CRY-ROP study, unfavorable outcome included disc and macular drag, traction there. And also unfavorable outcome was only macular drag. The vessels which are emanating from the optic disc, they are not arcuate fashion, they are going in a conical way. These were all unfavorable outcome in the CRY-ROP study. So what we have achieved with this new kind of classification is, we are now treating these babies early to get a better result, outcome. Just a small data, Parijat is a party to it, and we had 102 patients. 10% of the AP-ROP we had progression, which means that if you do the laser, despite laser, almost 10% of these babies progress. And this you have to keep in mind. And what are the factors? The factor is, one is the zone 1 disease. The second is presence of pre-retinal hemorrhage. If there is a pre-retinal hemorrhage, in a case where there is an AP-ROP or there is a zone 1 ROP, it is an ominous sign that this will progress, definitely. There is a need for retreatment. And if there is a fibrovascular traction more than 3 clock hours, this is also one of the factors for progression. And if the baby is less than 900 or 800 grams for that matter, the baby might go into severe ROP. Why am I saying all this? I am saying all this to have you an intuition. If you find these things in a baby, when you are seeing the fundus, your mind should start working. If you have 800 grams babies, if you have a say 28 weeker baby, this baby will definitely land up with severe ROP. Your mind should start working. So these things are very important. Now what does anti-VEGF do? And how do they benefit? It decreases the vascular endothelial growth factor. It decreases the inflammation. So what does it mean? If there is a case, APROP case, media is hazy, I will inject anti-VEGF to clear the media. Once the media is clear, I'll do the laser. Because remember, in a case of retinopathy of prematurity, avascular area is the culprit. No matter you inject the anti-VEGF, unless you knock out this avascular area, the thing is not going to settle. It may settle. You go on watching 3 months, 6 months, 9 months. The recurrence have been found after 9 months. See, the choice is yours. You want to wait for 9 months to have a complete regression, or you want that you should do the laser and have the results and be happy. The vascularization decreases after anti-VEGF injection, no doubt. The retinal edema is also less. That is known, as we use in cases of diabetic macular edema. And then the reaction is better. Of course, the edema is less, the reaction is better. Just show you 2 pictures only, 2. One is anti-VEGF preceding laser. I for one, and maybe Mangat also, and Subhadra also, maybe Anand also, maybe Narendran also, maybe Parag also, maybe Parijat also. We all use anti-VEGF as an adjunct. This is a case, 27-weeker child, 1100 grams, presented at 30 weeks to us, oxygen therapy for 16 days, history of sepsis. And sepsis, I'll stop here. And why do I stop here? I stop here because if sepsis is there, this is one of the very important risk factor for the progression of the disease. This child was referred to us from a government hospital, pupil not dilating well, posterior pole appears normal. Do these things go together? It doesn't go. If pupil is not dilating, you can't see the posterior pole. It's very difficult. And this child had rigid pupil, persistent tunica vascular, and vitreous haze. What did I? This is the picture. So what did I do? I injected intravitreal injection of bevacizumab. This child had plus disease and the media haze decreased. I did the laser for this child same day, PCA 30 weeks plus 3 days after injection of anti-VEGF. And this is post 14 laser day, and see this regression, complete regression is there. So this has been, the anti-VEGF has been used as a preceding to laser. This is another baby, this succeeding laser. Means laser I have done, despite laser there is some problem there, either a media haze, sometimes there may be a media haze after laser. Because again the laser is going to increase inflammation inside the eye. So 26-week child, 1060 grams, presented 32 weeks, PCA at this visit 34 weeks, referred from a private NICU, diagnosed APROP, and immediate photocoagulation was done. This is the picture. And what did you see here? You see there's a hemorrhage here. I injected bevacizumab. And why did I inject bevacizumab? I injected bevacizumab because there is a bleeding there, and if there is a pre-retinal hemorrhage, later it may be converted into a traction retinal attachment, and then there will be a problem. So I injected bevacizumab. See this picture. This area, you don't see anything. You see a little bit, a thick kind of fibrous kind of tissue here. This is 34 PCA, and this is 10 weeks post-injection. See this. This whole thing has gone. Little bit of small fibrotic tissue is there, and no traction on the retina. So One case I showed you preceding laser, the other case I showed you succeeding laser. This is just for surgery. I'll show you this case. Surgery, maybe, I'll show you some videos later. 29-week child, 39 grams, 37 weeks. Both eye had total retinal attachment, stage 5 ROP with open funnel, referred for management. And this is the picture. You can see this is the area which is the culprit. You can see here, torsity, you can see the total attachment and the traction folds. This is a lens sparing vitrectomy we did. And this is the picture, post-surgical picture. This is day 7 post-surgery. And this is day 28 post-surgery. Now, I'll just come to a little bit about the new innovations. One is the ultra biomicroscopy for seeing the surgical space. When we are doing the lens sparing vitrectomy, we have to be very cautious where we are entering. Is 1 millimeter or 1.5 millimeter, is a 2 millimeter. Anteriorly you go, hit the lens. Posteriorly you go, hit the retina. So one has to be very careful, and this thing we did in our center and we found this is helpful. And then this autologous plasmin enzyme, and this is the critical space we find between the retina and the lens, and it helps surgeon to plan a location. See this. You see the posteriorly closed and anteriorly open. This is the open, this is the posteriorly closed, this is the optic nerve. And see this is the sclera, this is the vitreomacular traction is there. This is the traction detachment, and this is the ciliary body. This is the lens, and there is a space here. You can enter from here. This is another case where, again, it is anteriorly open and posteriorly closed. And see this. This is the lens, and this is the traction retinal attachment, and this is the, if you enter here, you will hit the detachment, and if you go here, you will hit the lens. We did this small study, we found that it is helpful in assessing the anterior surgical space and helps in surgical decision. But most important thing is you need to have, some experience. You do 10-20 cases, then you will be able to have your own judgment regarding this surgical space. Now this is this pharmacological vitreolysis. This is in the market, and there are two types. One is the liquefactant, other is the interfactant. One is ability to liquefy the vitreous, and the other has ability to disturb the vitreous. Autologous plasmin enzyme, you must have heard about it. And this is an agent which has got both liquefactant and interfactant effect. Means liquefies the vitreous and disrupts the vitreous both. The high molecular weight is 88, larger molecule and shorter half-life. And this is the studies which have been done to the higher posterior retinal attachment rate to 69%, and also have a better posterior attachment in stage 5 ROP. And then this has come in the market, what we call as ochriplasmin, and what is marketed as Jetria. And this is a recently biological produced enzymatic enzyme using recombinant technology. And this is also a protease, and it has got both the qualities, where these are fibronectin and laminin, works against both the components, means it is liquefactant and also disrupted. If you compare ochriplasmin with autologous plasmin enzyme, the ochriplasmin has a smaller molecule, better penetration. It has got a half-life several times higher than APE, autologous plasmin enzyme, and it has been evaluated in randomized controlled trial, second 2-phase and the phase 3. So what I want to tell you is that disease APROP is a disease of very small and sick babies. Normally, to laser treatment, it is not very much responsive. What I am trying to say is the chances of failure is there when APROP is there. So anti-VEGF can be used as an adjunct, and stage 4A or 4B, one can do a lens sparing vitrectomy, but it's not an easy job. Many a times if you see that the ridge is attached to the posterior capsule behind, and you are unable to do a lens sparing vitrectomy. So lens sparing vitrectomy you can, do in a very selective group of patients, and even if the patient, if the case is good, even do a 25G vitrectomy for such cases. And then of course stage 5 is for conventional. I do conventional 20G surgery, and we do lensectomy. I also do a iridotomy, not iridotomy, an iridectomy rather, surgical iridectomy to make the pupil wide, because chances of, if you don't do that, chances of surgical post-operative phimosis and chances of reproliferation is very much in these babies. And of course these are the two things which has come in the market.